Thank you. I've got a few questions. I suspect they're for Dr. Chant in relation to the implementation of VAD, which I think is 28th of November is the rollout, is that right? And I've been looking at the clinical practice handbook, and look, tremendous resource, and I think will be very helpful for everybody, and I can see a lot of work has gone into that. Some questions in relation to how conscientious objection is being handled. I understand from the clinical practice handbook that the process means that the first step is that there's a first request form that is filled out, and that is submitted to the Voluntary Assisted Dying Board. What information will be on that form?
So the information, just to be clear, the information the conscientious objector has
Oh no, just generally what information is on the form? Yeah.
So all of the demographic details, the person who's requesting it, general information. I'm happy to provide you for the sake of time, a copy of the form.
That would be great. Thank you. No, that'd be very interesting. And who has access to that form?
So we've constructed a total separate secure portal that practitioners that are that practitioners can upload the data. So if you currently go to our website at the moment, you will see the introduction to that portal where people are able to register at the moment to be an authorised practitioner. So so at the moment you go in there, you log on, you enter your details, including your ARPA, you upload identification details. Our staff then look at whether you meet the eligibility criteria. So there are requirements under the Act.
Sorry, can I just stop you? I thought that there would be authorised practitioners, but that any medical practitioner who receives the first request has to upload the first form?
That's correct. So I'm just describing the portal. So the portal exists there at the moment, so you can go in and start looking at the portal. Right. Obviously that will then be expanded, for that portal will then take on the function of where forms will be uploaded.
And the form's uploaded and is stored
securely through an IT framework.
Okay.
We've gone out to tender and procured it. We're in the testing phase of that, and we'll be finalising the test environment in a couple of weeks. And obviously it won't go live until the 28th of November. Yeah. But there's been a lot of work with a lot of clinicians. It's very, I saw a run through yesterday, it's very sequential, and it will allow the board, support the functions of the board.
And so the first request form is filed if the doctor who's received the request happens to have a conscientious objection. That's recorded on the form. Who has access to that information? What are the privacy protections for the information in relation to the doctor?
Just like all health information, so it's under the whole health information form, but these are available in the context of to support the functions of the board. So I think people need to understand this is very secure information. It is treated like other health information.
And what other purposes could that information in relation to the doctor be used for?
I'm sorry, I'm just not sure what you're getting.
So could it be used, for example, if a doctor was applying for a different position or something to provide information in relation to a work review or something like that?
No, I couldn't see a circumstance where it would be used for that purpose.
No, that's great. No, thank you. All I'm seeking is clarification. That's all, just to fully understand it. In relation to junior doctors, so as I understand it, they often require recommendations from consultants, especially those perhaps on a training program, and those recommendations are important to progress their careers. What thought's been given to a situation where a junior doctor may have a conscientious objection but the consultant with whom they're working does not, so that their conscientious objection doesn't impede their career progress?
I think that I'd like to say that in implementation of voluntary assisted dying, it's been a privilege to lead the implementation and just acknowledge the work across the ministry. It's not just been our division, there's been work across the division and the local health districts and all our
and I acknowledge it's significant work that's been done.
At all points, we've just been respectful that the Parliament has made this a lawful option, but also has put in significant protections and acknowledged people's ability to be a conscientious objector. So like all other things, people's views and personal beliefs should not impinge at all. And that would really be for my colleague, Mr. Minns, to discuss how if anyone's personal beliefs, views, religious issues were at all taken into account in any career progression. So,
well, if I can assist you, and Mr. Minns, I'm also happy to get your views. That example is taken from an article written by University of Queensland academics Lindy Wilmot and Ben White, who drafted the Queensland VAD bill, and their paper that they've published argues that the right of conscientious objection can be an obstacle for the career progression of junior doctors. And so I was just wondering, looking at the difficulties they have flagged for career progression of junior doctors, how the New South Wales system had been designed to prevent this becoming an issue in New South Wales.
Well, I think that it's important that we, whilst I'll get Mr. Minns to comment on it, it's really important that we see a lot of these issues as general issues. So it might be around the fact that someone's got a particular view around voluntary assisted dying. It might be a particular view about another thing that persons hold dear. We as a system should not factor that in to their career progression. And so the usual pathways would be at play, but Mr. Minns.
Yeah, so we'd see that sort of consequence for someone in that situation. We'd see the exercise of that sort of decision making as being inconsistent with the code of conduct. So, you know, people
could you just say that again?
Well, people have a right to have their view, and they have a right that the Parliament has provided with respect to non-participation. So they should not therefore suffer a discriminatory response in the workplace. And if that was to occur, we'd consider it as a breach of the code of conduct, and they'd have a right to seek to have that behaviour reviewed and ceased. But it's an interesting point, and I might seek the reference that you've referred to.
Yeah, be happy to provide it. I was wondering, and I suppose I was hoping that rather than especially putting junior doctors and junior medical staff in a position where they're after the fact seeking redress, to what extent that New South Wales Health had been able to design into the implementation of this system proactive steps to protect conscientious objection and protect the rights of workers in that regard.
I think it's been clear in every document we've constructed around people's ability to do this, and we've also been incredibly respectful in our engagement, respecting the diversity of views and the fact that they're deeply held and profoundly held. And as I said, it is important that we protect people's rights to hold diverse views on a range of matters. And actually putting in that frame is probably the most useful in terms of linking it to the usual processes we'd have where people are experiencing these things rather than seeing as something unique. So we've taken a deliberative action that behaviours that don't respect people in the workplace or cause that thing would be dealt with use our usual framework.
No, and I think that's a good approach. I noticed that the practice handbook at 22 discusses the issue of self-care. I couldn't, though, see whether any guidelines have been established, because if you think about psychological practice, regular supervision to make sure that the psychologist has self-care, and if you think about the nature of the work we're going to be asking the VAD practitioners to engage in, I wonder what guidelines have been established for them to have self-care.
So look, the impact on providers has been considered, and there has been multiple forums. There's actually going to be a clinical practice group that's been established, and a community of practice, because we feel that that's the best forum to provide that system. In terms of our Care Navigator service, which is the sort of one front door for people wanting to seek advice, built into their system, they've built in psychological safety and debriefs and really attended to those issues. So it has been considered. And I also just want to acknowledge the incredible help that other jurisdictions have assisted us with in understanding the insights and sharing the learnings and we've taken that on board and built in those mechanisms which we think are most fit for purpose.
In the clinical practice handbook, it focuses largely on doctors. Just wondering, if I'm a nurse, if I'm a pharmacist, if I'm another healthcare professional, where would I go to look at processes for conscientious objection and protections around that?
So there's currently, there's been a series of webinars that we've conducted which are broad-based with, I think, a variety of different groups, GPs open to our local health district, open to our communities. We've done them with pharmacists as well. So there's been a lot of communication out there about the roles and responsibilities. On the website, there's also be a number of new information. So the clinical handbook was really tailored to those practitioners that are the authorised practitioners. Why it is so medically focused is that to be an authorised practitioner, it requires you to be a medical practitioner, except for the nurse practitioners can be administrating practitioners.
Perhaps again this raises this issue of responsive and proactive, and whether the responsibility, and I accept that this is a broader issue than this, and I think it's important that we locate it as a broader issue, but whether the responsibility should be on the healthcare worker to identify that there have been issues in their career progression because of views they might have and seek redress, as opposed to proactive statements and supports, and especially, I suppose, education of managers and those supervising them.
Look, I think it's a fine line. We don't want to braze our expectations that we would even condone or think that that could occur. I think you've raised the issue with us. We're very, cognizant of making sure that that happens in any of our engagement. But there's been a lot of work with our junior medical officers' presentations, and in all of those we factor in respectful engagement. And I've got to say that despite the diversity of views, I've always been amazed in all the sessions we've run around the respectful engagement that we've garnered in this, navigating this very difficult area.
Yeah, no, look, I think that's very encouraging. I'm aware from the clinical practice handbook, and as you've said, that for medical practitioners and nurse practitioners, they must meet specific criteria, required clinical privileges or scope of practice. I suppose I'm just seeking confirmation that the provision of voluntary assisted dying services would be regarded as outside the scope of practice for many doctors in New South Wales.
Well, to be an authorised practitioner and fulfilling those functions under the legislation, you need to undertake mandatory training. So the portal also is the way to undertake the mandatory training, and that training takes around 6 to 8 hours to complete and involves also an exam to pass, so a multiple choice questions. There are also face-to-face sessions for those that choose not or would prefer a more hands-on or iterative style, and they are run both metropolitan-based and regionally. So,
with respect to that training, just a question that arises, and you're probably aware of the experiences in the Northern Territory with the Rights of the Terminally Ill Bill, and you may be aware of that article that Philip Nitschke was a co-author of after that, where he reviewed, made his patient records available, significant diagnosis of mental illness, treatable mental illness, including depression, in a number of patients seeking to access that service. What component of the training for providers helps them identify mental health issues in patients that could and perhaps should be addressed before the request process is finalised?
Well, one of the key aspects of rolling out voluntary assisted dying in New South Wales is really trying to embed where it's aligned to people's goals of care as close as possible to the clinical services in which they're engaging. About 70 to 80% of cases from other jurisdictions has arisen in the oncology space. Clearly, the handbook, as you indicate, has a section on capacity and what is reasonably to do for capacity. But in terms of assessing it, they're very experienced, and the Parliament has set forth requirements that they are more senior practitioners, and those practitioners are responsible for assessing assessing those issues that might impact on the person's ability to make a commitment to, or express a informed desire and commitment to voluntary assisted dying.
So I guess, to paraphrase you, if I can test my own understanding, there is an expectation of clinical experience which would allow diagnosis, but there's no specific training that would help practitioners identify mental health issues that might that perhaps should be addressed as part of the request process.
I would expect that all of the practitioners putting their hands up for voluntary assisted dying would have, in the general course of their practice, many of them are general practitioners who would day in, day out assess mental health issues. They're the frontline health providers.
Can I just clarify though, Mrs. Carter, are you referring, when you say mental health, to competence?
No, I'm not talking... Sorry, excuse me. I'm not talking about ability to consent or mental competence. I'm talking about treatable depression or other things. The Philip Nitschke article in The Lancet clearly identified that there was treatable depression and raises the question of whether that should have been addressed before the request process would be finalised.
So I think one of the safeguards that we've really tried to implement it as very much of the care of the individual.
Mm-hmm.
And so what we're actually saying is if a person on a ward raises the issue of voluntary assisted dying with a junior medical staff, now clearly they can't accept a first request, but that actually should be dealt with as a need to explore, to raise with them more senior clinicians, and is it around pain management? Is it around access to palliative care? Is it around other psychosocial aspects? So in everything we've done in implementation, we've put the patient at the centre. So I'm actually very confident that the safeguards are there, and the Parliament has thought carefully around the prescribing the safeguards.
I guess I'm just exploring the type of training that is provided, and I think wanting to confirm that this is patient-centred and that all the issues that the patient has are explored, and I suppose also the concern about palliative care funding, that there is truly an option for palliative care that would sit truly alongside a VAD option, so that these are effective choices.
Absolutely. And palliative care, it doesn't matter if someone's in a clinical trial, it doesn't matter if someone's continuing aggressive therapy, it doesn't matter if someone is choosing to have... I would expect most of these patients to be engaged in palliative care. And when I mean palliative care, I mean optimum symptom control, optimum pain management.
Because I think Parliament was clear that what they were looking for was to provide choice, and you have to have properly funded and available and accessible palliative care in the city and in the country for there to be an effective choice available to patients.
Every component of the implementation, including with all of the practitioners that we've ever engaged with around this issue, and it's been extensive clinician engagement, we've really highlighted the importance that someone raising voluntary assisted dying, it's an opportunity to check that all of those other things are not impacting on the decision. It's clearly outlined in the clinical guidance, and that's been the way it's been implemented. And very much that's why keeping close to the teams, and we also would encourage people, notwithstanding Parliament has allowed people to not raise it with, keep it separate from their families, or also not with their treating teams. We've really encouraged that it's as close as possible, because we feel that particularly that the treating teams will know best around the person's clinical condition, but also any psychosocial factors.
Can I just add one last comment to that? I think that in the normal course of things, treating patients for whatever condition or area of care they're in, our staff are used to referring patients to other specialists as well if an assessment is required. So, particularly in the case of a mental health concern where, perhaps further specialist advice was required, I can imagine that would be no different in these circumstances.
The Act actually permits that, and it specifies that expert advice can be seek, and the clinical handbook covers those circumstances where you might bring into question that you want to seek external expert, whether it be about prognosis or mental health capacity.